Let me tell you about a woman I'll call Rose. She's 74. She takes a blood pressure pill in the morning, a cholesterol pill with breakfast, something for her joints when they act up, a pill for her stomach because the joint medication upset it, a pill to help her sleep, and a multivitamin because her daughter insists on it. 6 things a day, sometimes more if her knee is bad. Rose isn't unusual. She's completely normal. And that's exactly the problem I want to talk to you about today. Because what's happening to Rose is happening to tens of millions of older adults right now. And almost nobody is talking about it in a way that's actually useful. It's called polypharmacy. That's just a medical term for taking multiple medications at the same time. And by most definitions, it kicks in once you're regularly taking 5 or more. It sounds clinical and a little abstract, but the numbers behind it are not abstract at all. Research tracking U.S. adults over the past few decades has found that the share of older adults taking 5 or more medications has climbed dramatically since the 1990s. And today, something in the range of 4 out of every 10 adults over 65 fall into that category. Some studies put it even higher once you count over-the-counter drugs and supplements. This isn't a fringe issue affecting a few unlucky people. It's the reality for a huge portion of the older population, including maybe you or your parent or someone you're caring for right now. Here's why this matters so much more as we age, and I want to walk through this carefully because understanding the why is what makes this information useful instead of just alarming. Your body at 75 does not process medication the way it did at 45. Your liver, which breaks down most drugs, slows its metabolic activity as you get older. Your kidneys, which filter drugs and their byproducts out of your bloodstream, gradually lose filtering capacity, often significant amounts of it, by the time you're in your 70s and 80s. Your body composition shifts too, with less muscle and more fat relative to your body weight, which changes how certain drugs distribute and how long they stick around in your system. None of this means medications are dangerous or that you should be afraid of them. It means the same dose that was well tolerated at 50 can behave differently at 75, and a medication that's perfectly fine on its own can behave differently when it's combined with 4 or 5 others. That's the core insight I want you to walk away with today. It's rarely just one medication causing a problem. It's the combination. Each new prescription usually gets evaluated on its own by whichever doctor is prescribing it. Your cardiologist reviews your heart medications. Your rheumatologist reviews what you're taking for your joints. Your gastroenterologist looks at your stomach medication. Each one is likely doing their job carefully and well. But there isn't always someone whose job is to sit down with the entire list, all of it together, prescriptions, over-the-counter drugs, supplements, and ask a very simple question. How are all of these interacting inside one aging body at the same time? That gap, more than any single dangerous drug, is where a lot of the real risk hides. We actually have solid data on how often this leads to real harm. The Centers for Disease Control and Prevention has tracked emergency hospitalizations caused by adverse drug events in older Americans, and the numbers are sobering, close to 100. 000 emergency hospitalizations a year in adults 65 and older are linked to medication-related complications. That's not a small footnote in public health data. It's a substantial and largely preventable driver of hospital admissions in this age group. Interestingly, when researchers looked at which medications were most often responsible, it wasn't some obscure or exotic drug. The most commonly implicated medications were things like blood thinners, such as warfarin, insulin, other diabetes medications, and antiplatelet drugs used to prevent clots. These are all medications that are absolutely necessary for the people who need them. The issue isn't that these drugs are secretly harmful. It's that they have a narrow margin between an effective dose and a dose that causes problems, which means they require careful, ongoing monitoring, especially as kidney function and body weight shift with age. I want to pause here and say something clearly, because it matters. Nothing I'm telling you today is a reason to stop taking any medication you've been prescribed, or to view your doctor as someone withholding information from you. The research on adverse drug events isn't hidden. It's published in mainstream medical journals, discussed at medical conferences, and increasingly built into the training of geriatric specialists and pharmacists. The challenge isn't secrecy. The challenge is coordination, time, and the sheer complexity of managing multiple chronic conditions across multiple specialists. Your primary care doctor might have 15 minutes with you. Your pharmacist might be filling 40 prescriptions an hour. Nobody set out to create a system where medication lists quietly grow more complicated every year, but that is often what happens. One reasonable prescription at a time until the list itself becomes a risk factor. So let's talk about what actually goes wrong when multiple medications interact, because understanding the mechanisms helps this all make more sense. One common issue is what's sometimes called a prescribing cascade. This happens when a medication causes a side effect, and instead of that side effect being recognized as a side effect, it gets treated as a brand new medical problem, which leads to a brand new prescription. A classic example involves certain blood pressure medications that can cause swelling in the ankles as a side effect. If that swelling gets treated with a diuretic instead of being recognized as a medication side effect, you've now added a second drug to manage a problem the first drug created. That diuretic can then affect potassium and sodium levels, which can affect heart rhythm, which might lead to yet another medication. Each step along the way looks like reasonable medical care. But the total picture is a medication list that has grown, not because the person got sicker, but because side effects kept getting chased with new prescriptions instead of being traced back to their source. Another real and well-documented risk is falls. Medications that affect the central nervous system, things like certain sleep aids, some anti-anxiety medications, certain antihistamines, and some medications for pain can cause drowsiness, dizziness, or slowed reflexes. On their own, at appropriate doses, many people tolerate these fine, but when several of them are combined, the sedating and blood pressure lowering effects can stack on top of each other in ways that aren't always obvious until someone stands up too quickly and feels the room spin. Falls in older adults aren't a minor inconvenience. They're one of the leading causes of injury-related hospitalization and loss of independence in people over 65. And medication interactions are a recognized contributor to fall risk that geriatric specialists specifically screen for. There's also the matter of nutrient absorption, which is a subtler issue but a real one. Certain medications, when used long-term, can reduce the absorption of specific vitamins and minerals. This is well established in the research, and it's exactly why doctors who prescribe these medications for extended periods are supposed to monitor for deficiencies over time. Not because the medication is secretly toxic, but because long-term use changes digestive chemistry in ways that are predictable and manageable, as long as somebody is tracking it. This is a great example of why regular medication reviews matter so much. A medication that was exactly right 5 years ago might need a companion supplement or a periodic blood test today, simply because 5 years have passed and your body has changed. Kidney and liver function are the other piece of this puzzle. And I mentioned this earlier, but it's worth sitting with for a moment. As kidney function gradually declines with age, which happens to some degree in almost everyone, medications that are cleared by the kidneys stay in the bloodstream longer than they used to. This means a dose that was calibrated for someone with younger, more efficient kidneys can end up being a slightly higher effective dose in someone whose kidneys are working at 60 or 70% of peak capacity. This is precisely why geriatric medicine as a field pays so much attention to kidney function tests when managing medications in older patients, and why doses sometimes need periodic adjustment even when nothing else about your health has obviously changed. Now, I know all of this can start to feel overwhelming. So let's talk about what you can actually do, because this is the part that matters most. The single most valuable thing you can do is what's sometimes called a brown bag medication review. It's a wonderfully simple idea. You literally take every single thing you're taking, every prescription bottle, every over-the-counter medication, every vitamin, every herbal supplement, and you put them all in a bag and bring them to an appointment specifically set up to go through the entire list together with your doctor or your pharmacist. Not a rushed 5 minutes at the end of an appointment about something else. An appointment where reviewing the full list is the actual point. Many pharmacies and primary care practices now offer this specifically, sometimes called a comprehensive medication review, and it is one of the most useful and underused tools in modern healthcare. When you're in that review, there are a handful of questions worth asking about each medication on your list. What is this treating? And is that condition still present? How long have I been taking this? And was it originally meant to be short-term? Is there a safer or simpler alternative now that wasn't available when I started this? And importantly, could any of my symptoms, the fatigue, the dizziness, the stomach upset, the forgetfulness, actually be a side effect of something I'm taking rather than a new problem needing a new prescription? That last question in particular is the one that catches prescribing cascades before they start. I also want to specifically mention pharmacists here because they are one of the most underused resources in this entire picture. Pharmacists are medication experts. They train extensively in exactly this kind of drug interaction analysis, and many pharmacies now offer dedicated time for medication therapy management, often at no extra cost, particularly for patients on multiple long-term medications. If you have a complicated medication list, your pharmacist can run it through interaction checking software, flag anything that needs a second look, and communicate directly with your prescribing doctors. This is exactly the kind of coordination gap I mentioned earlier, and pharmacists are trained and positioned to help close it. There's also a tool many geriatric specialists use called the Beers criteria, which is a regularly updated list maintained by the American Geriatric Society of medications that carry particular risks in older adults and may need extra caution, lower doses, or closer monitoring. You don't need to memorize this list yourself. What matters is knowing it exists so that if your doctor or pharmacist mentions it, you understand they're applying a recognized, well-established clinical standard, not making an arbitrary judgment call. I want to be really direct about one more thing because it's important and it's easy to get backwards. If you're watching this and thinking about a medication you take, please do not stop taking it or change your dose on your own based on anything you've heard here or anywhere else. Some medications, particularly ones for blood pressure, heart rhythm, and blood sugar, can cause serious problems if they're stopped abruptly, sometimes worse than the risks of continuing them. The entire point of everything I've described, the brown bag review, the pharmacist consultation, the questions to ask your doctor, is to have this conversation with the professionals who know your full medical history, your lab values, and your specific situation. This is a let's figure this out together conversation, not a throw away your pills decision. There's a term for the process of safely reducing or simplifying medications when appropriate. It's called prescribing, and it's become a legitimate growing area of clinical research and practice over the last decade or so. It is not about being anti-medication. It's about periodically asking whether every medication on a long list is still earning its place given the person's current goals, current health status, and current risk profile, and doing any changes gradually with monitoring and always in partnership with a doctor. If your doctor brings this up, or if you bring it up and they're receptive, that's a good sign of thoughtful, individualized care, not a red flag. Let's go back to Rose for a moment, because I think her story, in a version like this, plays out in doctors' offices and pharmacies every single day, and it usually ends well. Say Rose mentions to her pharmacist that she's been feeling unsteady on her feet and a little foggy in the mornings. Instead of that becoming a new diagnosis and a new prescription, her pharmacist looks at her full list and notices that her sleep medication and one of her older pain medications both have mild sedating effects. And together, They're compounding in a way that's more noticeable now than it was a couple of years ago, before her kidney function had declined slightly with age. That's not a dramatic discovery. It's a quiet, unglamorous piece of clinical detective work. But it's the kind of finding that, addressed properly with her doctor, might mean a lower dose, a medication swap, or simply better monitoring. And it might mean Rose feels steadier on her feet and sharper in the morning within a few weeks. That's what good medication management looks like in real life. It's not dramatic. So here's what I'd love for you to actually do after watching. If you're managing multiple medications yourself, or you're helping a parent or a loved one who is, schedule that comprehensive medication review. Call your pharmacy and ask if they offer one. Gather every bottle in the house, prescriptions, over-the-counter drugs, vitamins, herbal supplements, all of it. Because your pharmacist and doctor can only spot interactions in the medications they actually know about. Write down any symptoms you've noticed lately, even small ones like dizziness, fatigue, or memory changes, because those details are exactly what help a professional connect the dots between a symptom and a medication rather than a symptom and a new diagnosis. And if you take one thing away from everything I've said today, let it be this. Managing multiple medications safely as you age isn't about fear, and it isn't about mistrust of your doctors. It's about coordination. It's about someone occasionally stepping back and looking at the whole list together, the way no single specialist is always positioned to do on their own. That's a solvable problem, and solving it starts with one appointment, one bag of pill bottles, and one honest conversation with the people whose actual job is to help you get this right. Take care of yourself, and please, talk to your doctor or pharmacist before making any changes to anything you're currently taking.